for today. He has been a physician on our faculty here since 2010, part of the University of Minnesota community since his ID fellowship days began in about 2006. So he's well known to us. He's going to be talking to us about Lyme disease, Tic-Tock 2 for some nice alliteration. Lyme is something that, obviously is endemic to this region, and it's something that whenever we have swollen joints in ED setting, hospital setting, clinic, urgent care, specialty clinics, etc., that gives us pause, and I think we're all going to learn something new about it today. Please join me in welcoming him. Thank you.
Good morning. So my talk is Tic-Tock 2, time for an update about Lyme arthritis, and I promise to explain and everything, and even why the name is so weird. So I do not have any financial conflict of interest to disclose, and I will not discuss any off-label use of medication or procedures. There is a little asterisk there, because at one point I am going to talk about doxycycline, and I am going to talk about doxycycline being given to children even under the age of 8. I don't even know if it's off-label those days, because again, as we'll see, more and more people doing it. So I don't know if I'm considering it as an off-label use or not, but definitely that's going to be discussed, and it's something we need to mention. So the objective of this talk are first to describe the clinical presentation and epidemiology of Lyme arthritis in our region. I want you, in the end, to be able to interpret the commercially available Lyme screen, how to diagnose Lyme, fast and easy, and to create a management plan for a child presenting with acute arthritis. So why Lyme? Why Lyme arthritis? A year and a half ago, I was here and I gave a talk called Tic-Tock, Time to Rethink Joint Knee Swelling. Thank for Jeff Louis about the title. And ever since then, I kind of using this talk, and this is a sequel for that. This is the number 2. It's an update. And my whole work here started with an observation as a fellow that I kept on saying those kids, this typical story that I'm sure many of you who work in the hospital is familiar with. 4 or 5, 6-year-old, perfectly healthy boy showed up at the ED with a swollen knee, get tapped, get more than 50,000 white blood cells in their synovial fluid, get diagnosed as septic arthritis, get admitted to the hospital, IV antibiotics, surgical procedure. 2-3 days later, the culture is not coming back positive, so we are calling him culture negative septic arthritis. The following day, the Lyme Western blot IgG come back positive as 9 to 10 bands. Kid is diagnosed with Lyme arthritis, sent home on amoxicillin, everyone's happy. I saw it once, I saw it twice, I saw it 3 times, and then I started thinking about it, like, we're missing something here. Those kids can definitely be handled differently. Then I did some digging, and apparently there is some literature that shows up that, this is not the way to deal with those kids. And these 50,000 white blood cells in a synovial fluid that we were was told to us by a higher authority that it's septic arthritis, period. It's in fact not exactly that. And out of all places, it came from the ortho kind of literature, from the Northeast. So I remember trying to kind of manage patient according to that, but I was extremely frustrated that it didn't work. Still, providers were kind of choosing to err on the side of caution, and kids kept on being admitted. So that brought me to look at this whole thing of synovial white blood cells and septic arthritis and Lyme arthritis. And that's what I presented here a year ago, and we were able to prove what was already proven, that synovial white blood cell is not an indicator of either the absence or the presence of septic arthritis. But what also got me during that project is really got hooked on Lyme. Really got interested in Lyme. So why am I so interested in Lyme? So first, the observation of clinical need, it's still there. I think we're doing better. I think less kids are being admitted and less kids are being mishandled like that. But we still, every now and then, see children who spend a couple of days in the hospital with IV antibiotics. But Lyme is a fascinating disease, really. Everything about Lyme is exciting. Everything from the history of the discovery of the disease, the social impact of that, the interaction between the animals, the human, and the environment. The patient population is really fun to work with. Those are usually healthy children, healthy families. They go to their cabins every now and then. They're very outdoorsy. It's really kind of population that is fun to work with. It's an easy and good disease to treat. It's easy to recognize. It's easy to treat. And really, usually, the prognosis is excellent. So it's fun. But every now and then you get the occasional curveball that is a bit more challenging, which as a provider is something I find very interesting. It's a multidisciplinary interaction. Primaries, ED, hospitalists, IED, surgeons, everyone have something to do with that. So really a lot of people are involved, and really you get to work with a lot of different disciplinaries. So this is fun. And the host pathogen interactions are fascinating. I'm going to talk about that. And something that, again, to tie it all, this whole concept of immune dysregulation, Lyme arthritis can definitely serve as a model for that. So anyone who is interested in the immune system and kind of why things are happening as they're happening, Lyme arthritis is kind of a fun thing to think about. So, if you think about the pathogenesis of Lyme, and if you talk about Lyme, you need to start in the beginning. And the beginning here is the tick. So it really starts with the tick, and there are a lot of cool things about those ticks. Now, don't get me wrong, I do not like tick. Usually I do like animals, those who know me. I'm vegetarian, I'm the one who will pick up a spider and send them out, put them outside. But I do draw the line with my blood. So when you suck my blood, you're out. So ticks as individual, kill them when I can find them. As a species in general, not my favorite, but they're still very exciting, and there are a lot of things. For instance, they have certain proteins in their saliva that interact with our immune system, that are inhibit complement, that inhibit polymorphic PMNs. They use that so they'll be able to attach to our body and have a blood meal, which is a much better phrase than a host-tick interaction. I love this phrase, blood meal. But during a blood meal, the tick has to have a special mechanism that will allow it to stay there and the body not to recognize that. And it's kind of cool to see all of those proteins that the tick has. Then it goes to the interaction between the tick and the Borrelia, and it's weird to think about a tick as an animal with an immune system, but the Borrelia, in order to survive, has to have different mechanisms to survive inside the tick against the tick immune system. So there are certain proteins that are being upregulated when the Borrelia exists inside the midgut, probably in order to get persistent there and to attach to the cell. But when the Borrelia move to the salivary glands, those same proteins are being expressed much less and kind of disappear, probably just to take down the antigen burden. So it will be easier for the Borrelia to survive there. But at the same time, there are some other proteins that are being upregulated while in the salivary gland, and those are proteins that the Borrelia itself sometimes use together. And those are proteins in the Borrelia that sometimes use salivary gland protein of the tick to form a synergy and to attack the immune system, again, by inhibit complement and by inhibit polymorphic nuclei. But then when the Borrelia gain access to the body, there are a lot of mechanisms that help the tick to survive there. So it starts with proteins and starts with some factors that interfere with the innate immune system. And then it moves to some other part, especially a specific surface protein that I'm going to talk about again and again today called VLSE, which is a variable surface protein in the tick that allow for the persistence, that really confuses the body in a way that we're going to speak about a bit later, and allow the Borrelia to gain access, to disseminate, and then to produce like a chronic persistent infection. A lot of host genetics, we are well aware of a couple of HLA alleles that are associated with the antibiotic refractory Lyme arthritis. Probably there's way more to that than we know, but definitely the host factors and the DNA play a really important role. And then the Lyme arthritis itself. I personally don't understand why the knee is in the end place of of this whole process, and why it's the knee that swells up. But we are very well aware about specific proteins in the Borrelia that are upregulated while in the joint and serve as a pro-inflammatory to create inflammation and create arthritis. So, as you see, it's kind of a Swiss cheese model of accidents. I mean, you need to have a lot of things aligned in order to end up with a swollen knee. But when you do, and I forgot the almost most important thing. So another thing that we need to think about in Lyme disease and the whole tick environment and tick interaction can be a model of its climate change. We are very well aware that the numbers of Lyme disease increase. Many hypothesize, including me, that it has to do a lot with climate change. But in my household, climate change are my wife's issues, not mine, so I will leave it at that. But when you do talk about us, outside of the climate, so a couple of things about immune dysregulation. So the immune system is a complicated system. And just in order to survive, just in order to, be who we are and healthy, there is a lot of energy at any given moment that the immune system put into regulating itself. It's like the military police of the military. And there are a lot of factors that can interfere with that. And any small interference can create some sort of a clinical disease. So some microorganism can cause disease by a direct attack, by direct damage, by occupying space, by producing toxins that are directly affecting the body. But in fact, even most infection cause tissue damage and cause the disease that we are seeing as a clinical disease due to the immune system. In fact, in pediatrics, when you take out the structural and the metabolic diseases, really almost everything we see is connected to the immune system. Rheumatology, endocrinology, GI, renal. I'm sure all of you, everyone here deal with diseases that, although have different etiologies, all have this immune system part of them. A lot of the damage we see in kids are self-inflicted wounds that our system does to itself. And it's always very interesting to see why and how. And, we have definitely a lot of theories about infectious diseases, being triggered for that. The classic model is rheumatic fever. But the lists go on and on and on. And, there is an alphabet suite of HSP, HLH, MS, DM, ADEM, GBS, PANDAS, reactive arthritis. Again, I can sit here for another 10, 15 minutes and just throw names of diseases that most of us are pretty sure are some interaction between an exposure to an exogenous antigen and immune dysregulation. And there are 4 mechanisms that were suggested about how an infectious antigen or how an exogenous antigen can dysregulate the immune system. One, and kind of the one that it's easy to think about, and the one that rheumatic fever seems to use, it's molecular mimicry. That just a close enough resemblance between the foreign antigen and some self-epitope. Another theory, the epitope spreading, and this is a theory that due to a persistent infection, there is enough tissue damage that enough self-epitopes are being released into the environment to trigger an immune system, trigger the production of self-clones. The bystander activation is the vicious cycle theory that when too many arms of the immune system work at one time, they kind of trigger each other to produce more and more and more and more inflammation and this vicious cycle. This is the bystander activation. And then the third one that it's kind of also a mystery to me, and there's not much evidence about it, it's like the retained cryptic antigen, and that's a theory that there is some certain antigen that is completely invisible to the immune system, somehow kind of stay around and does produce some sort of inflammation that released epitope to the environment. So this is kind of what really interests me in Lyme. So it's not, and what I'm doing here and what I started to do about is try to put as many pieces into that puzzle of answers and to try to use it as a model. So as I said, I started with this comparison between septic arthritis and Lyme arthritis. So I came really from the clinical part. So the way I started to work on Lyme was really to go from the clinical disease, from the bottom part of that, to try to explain that, to try to understand that, because if we do want to understand this model, the base for that many times, at least for me, is the clinical presentation. So let's talk Lyme. So the beginning of Lyme in 1977, it all started with 2 concerned moms that noticed that in their little small community of 12,000 people, there is an epidemic of a JIA and rheumatic arthritis. Again, those who do see real JIAs, I can tell you that the incidence of that is probably less than 50 to 12,000. So they contact the Connecticut Department of Health, who in turn contact Yale University, and this is where Steers and Malawista, do I say his name right? Took on the project. At that time, Steers was a first-year fellow. Everyone here who is in their first or second-year fellowship know that if you catch the right project, you can live on that for the rest of your life and being renowned for some good discoveries. Again, I always think about that when I think about the Rochester criteria that we all live upon and were written by a first and second year fellow at that time. So Steer in 1975, when they wrote it, was a first year fellow. And when they got involved, they start asking questions and then doing physical exams. The joint itself, the swelling itself didn't take them too far. But what they did observe that all of those patient that had the story, the joint problem, also had this weird story about an expanding rash, and they went to the literature And they found that, oh, someone described this rash years and years and years ago and called it erythema chronicum migrans. It, in fact, was first described in Sweden in 1909, and it was thought to be associated, maybe yes, maybe not, with ticks. So Steer got this piece of information, went back, this very, nice diagram of the patient, of the pattern of their joints, of their time, of their age. And that's how they came up with the hypothesis that, hey, this is something that has to be with infection. This is something that probably is arthropod borne. They had really no idea why, and the whole pathogenesis that I spoke about this first slide was completely unknown. But just observation was smart enough and good enough to put us on the right direction. And then within several years, Willy Burgdorferi was able to isolate the treponema-like bacteria, which we all call now Borrelia burgdorferi. Throughout the years, there were a lot of clinical theories to describe what it looked like. And what we know now that Lyme arthritis is usually mono or oligo-arthritis. It's most commonly affecting the knee. It can affect some other joints, sometimes ankle, hip, shoulders, elbow, wrist. It's present with a large effusion, with warmth, but not particularly painful, and there's a range of motion and weight bearing usually stay there, and fever is usually not present. A word of caution, Lyme arthritis is by far, at least for me, the most common presentation of Lyme disease. And I'm fully well aware that Lyme disease, it's more than just the arthritis. But how I look at that, it's the arthritis part. So I will say Lyme disease and Lyme arthritis intermittently. I will mean the same thing. The recurrent guideline for diagnosis, and I hope all of you are aware of this table, and I hope all of you are going to not really appreciate this table in the end of the talk like I am now, but definitely be aware of that. So for more than a decade now, and I forgot exactly when that was published, that is how we're told to diagnose Lyme disease. You do it with a two-tier step. The first step is a screen, which is usually an EIA assay on a whole cell lyset. If that is positive, then we move to the second stage, which is a bit more specific. So the thought behind that was that the screen test, it's easy, it's cheap, but it's not very specific, but it's very sensitive. The problem with that it takes a while and it costs a lot of money, and it's kind of confusing. And part of what brought me into this project is to see if there's any better way to diagnose and to manage, because as we saw what kind of the observation we made before about the patient with arthritis being admitted, that was the reason why they had to stay in the hospital for 4 days. If for some reason we'll be able to do that earlier, we probably would shave 3, 4, 5 days out of the hospitalization. Some progress was made in the guidelines about how to treat it. So those guidelines were published 2 years ago, or now 3 years ago, so relatively recent. I'm not going to get into too much details. The numbers are there. You can always go refer to them. What I do want to mention are a couple of changes. There is a move into a short duration of treatment. There move to an oral treatment, even for the meningitis or the bad arthritis. And also, there is a move to change from IV to PO as early as possible. So, even patients are diagnosed with Lyme neuroborreliosis or Lyme meningitis, oral doxycycline is what's recommended now. And it seems to be the right medication if they're stable and if they're not too sick. And this is also when I'm going to mention a few words about doxycycline. Doxycycline, and there is more and more evidence out there that it is safe for children under the age of 8. I'm not saying that start giving it for 4, 5, 6 weeks treatment, but especially for diseases like Lyme disease, when they're not very good option, they are, but they're not very good, or definitely not as good as doxycycline. Don't be too concerned about giving a week, 10 days, even 2, 3 weeks of doxycycline if you think this is the right medication to give. You cannot have a Lyme talk without having the map. Again, I'm sure all of you are aware, and when I was in Ohio, I did not know what Lyme disease is, and when I went to medical school in Budapest, Hungary, I remember kind of working and learning about Lyme disease with a picture of Lyme in my head, because that's the only thing I could connect, and it was a very obscure thing for me. It's not very obscure and abstract now. This is a very real thing around here, as you see from that map. Our local epidemiology, it's also something that I think all of us need to be aware. So there's definitely an overall increase, a bit of fluctuation in the last 5, 6, 7 years, but definitely an overall increase. A couple of thoughts why this increase are, and people are talking about it. Is that better diagnosis? is that people are more aware of that, or what I also think, there's just more Lyme disease. Go back to the climate change discussion that we had. But it's definitely not a trivial issue here. It's something that we all need to know about. So with all of this information and all this background, I set a goal, at least for this project, to try to identify as comprehensive as much as I can of a cohort of patients with Lyme disease, to get as many kids with that, to try to understand exactly what their clinical presentation look like, because if you remember, this is kind of the first block or one of the blocks in understanding immune dysregulation. And then when we get them to review and to characterize their clinical presentation, and the goal for that was first to understand how they look, so we can give some guidelines to the providers who see them to take the right decision and not to overreact and not to use too aggressive of procedures when they are not needed. And also for the research part of that, to see if it can help us anything about the immune dysregulation model. So the method was, in fact, a combination of two different projects. The first project was a project that I looked at all joint complaints presented anywhere in Fairview between January of 2011 to July of 2016. That was designed like that in order to compare between septic arthritis and Lyme arthritis. But out of that project, I took all the patients with proven Lyme arthritis, and I added to that a second project that took place between January 2015 to December 2017 that looked at all of the Lyme screen that were done at Fairview to see how many of them were positive, and then to review the chart of the patient with positive results. Patients were excluded if they have any other alternative diagnosis from septic arthritis that is proven and treated, through trauma, rheumatological diseases, or many patients who did not even have a joint swelling. After taking a big chunk of patients, the inclusion criteria it was very important to really have patients that are unquestionable Lyme arthritis, that we are sure they have that. So patients were included only if they have a positive Borrelia PCR on their synovial fluid, or if they had a positive Western blot and documented arthritis in the note, and I did not add here, were not treated in any shape or form for septic arthritis. We end up with several hundred patients, around 200 that we had to review a bit more in details. And for those patients, we took the following clinical information. I will not go through that list because we're going to show the results. But that's what I found. That was the first thing. So first thing I want to explain is how I define the acute versus the recurrent presentation. So every patient who had one-time presentation of a joint swelling that lasted less than 2 weeks was defined as acute. Everyone else was defined as recurrent. With defining recurrency as anyone more than 2 weeks, you run into some problems. Because some patient just showed up with a swollen knee that happened yesterday, but when you start asking them, it also happened 2-3 years ago. So those are defined as recurrent. Exactly who they are they more to the recurrent pathophysiology versus this is just as another acute presentation? It's hard to know, but they were definitely defined in this project as a recurrent. And another issue was some patients have an acute presentation just misdiagnosed. And every now and then you'll see someone coming to clinic or coming to an ED and say, hey, I have a swollen knee and it's been swollen for 2.5 weeks. So this is probably an acute presentation, but if it lasted more than 2 weeks, at least per documentation, I included them in the recurrent group. So those are the group I found. So in total, it was 109 patients. 67 of them had acute Lyme arthritis. 42 of them had recurrent Lyme arthritis. The acute Lyme arthritis could be further divided into acute monoarthritis, 61, acute polyarthritis, 6, recurrent mono, 19, and recurrent polyarthritis. Make it a bit easier to look at it like that. So this is the 109 patient report. And as you see, 62% of them had acute presentation. And let's do my math here. 7, 6. How much were you here? Well, I need my math. 63 have monoarthritis. But by far, you can see that the most common presentation of Lyme arthritis is an acute monoarthritis. 56% of all patients present like that. So that's a busy slide, and it's a bit of a busy slide on purpose, and I will tell you, really don't look at the numbers. Don't try to make sense out of the numbers. If you'll try to make sense out of the numbers, you'll fall into a rabbit hole that's not going to help you much. And the point of that is that the numbers here don't really help much. They are male predominant, but most of their labs, and definitely the inflammatory markers, are very inconclusive. Some of them are high, some of them are low. Point is, it's really not a basic lab type of a diagnosis. This is not something you can do CBC, ESR, CRP, and get your diagnosis. Few things that did catch my eye is the peripheral white blood cells has always been normal. Out of the 109 patients, there was one patient that had 16.1, and except that specific patient, everyone else was below 15. So if you do have a high white blood cell count, it's probably not Lyme arthritis. Again, probably, but it's something that kind of struck my attention. Something else to pay attention is the synovial white blood cells. So if we say that the peripheral white blood cells is always normal, the synovial white blood cells is always elevated. And it's usually elevated to quite a high degree, to the same degree that we think septic arthritis should have, to the 50, 60, 70,000. It's also always PMN predominant. It's always neutrophil predominant. I don't think I've seen a patient with Lyme disease, with Lyme arthritis, that we had a synovial fluid with less than 95, 92% of PMNs. So that's what you should expect. You should expect like a 30, 40, 50,000 white blood cells with mostly PMN. And something else that was interesting is the admission rates. So overall, when you look at admission rate, it's 13%. But when you look at this patient with the acute presentation, we're talking about 20, 25%. That's a lot. That's a lot. I think the one thing that there is no doubt that patients with Lyme arthritis do not need to spend time in the hospital. The confusion and discussion is, how do we know it's Lyme disease? Lyme arthritis is not what I'm going to discuss. And part of the goals of the kind of overreaching goals of what I was trying to do is to reduce that, is to really take down those numbers. Few more numbers, because there's nothing like a early morning with a lot of hard numbers to look at. So this is the Lyme studies that we took out of our 109 patients. What I will tell you is a couple of things to pay attention. First, the Lyme screen is 100% positive, but, you know, that's easy because that's kind of the definition. We know that if someone has a negative Lyme screen, we don't even consider Lyme in them, so the fact all of them have positive doesn't mean much. But the Western blot IgG is not only it's positive, it's really positive. It's usually at the 9 to 10 band. Every now and then you'll see lower band. There is a kid here with 5. But when you look at the means, it's above 9. So it's definitely, when you do this test, the number of IgG bands tells some story. On the other hand, the IgM bands are kind of a hit or miss. Half of them are completely negative. Definitely not a useful thing to work with. Something else that is interesting is the PCR. The Borrelia PCR from the synovial fluid was 64% positive in those it was checked in. And again, there is a lot of discussion and theories why it's not always positive, but it's also something to remember. So it's something that if you check, it has very high specificity. If it's positive, it's probably Lyme, but if it's negative, that does not rule out Lyme. But what really caught my eye was this part. So in 2015, there was a change in the type of Lyme screen that was performed here at Fairview. And instead of just getting a yes or no answers, we started getting a no or a yes with a number. It is a quantitative test. Everything above 0.9 is positive, but the test range goes up to 12.4. But what I start noticing that all those patients with Lyme arthritis came back not only positive, but they came back positive with a really high number. And most of them were above 12.4, which is kind of the highest, and it's just stopped counting after this point. So that caught my eye. And as I said, with the VLSE, and this is a specific protein that's being checked by that specific Lyme screen, as I said before, we're going to come back to that, and we will, because that's something that really I find interesting, and I got some nice results about it. So the seasons. I remember as a fellow having a discussion with a senior provider about a child with joint swelling, when I say, hey, maybe it should Lyme. And then I got the look, I was like, oh, no, this is February, you should learn more. So I did, and it can still be Lyme. So Lyme, it's a year-long disease, and I think it's very important to remember that. It's definitely more common in the fall, as you see the numbers, but kids can present with Lyme disease throughout the year. So it's never a good answer to say in the middle of the winter, it's probably not Lyme. it's the middle of the winter, it can definitely be Lyme. It can be Lyme because this disease is reactive. It's a disease that takes a while to develop. And it can also be Lyme because of climate change. A couple of years ago, it was 80 degrees on St. Patrick's Day. The ticks don't know what the date it is. They only know how much sun and what the temperature is. So the change in weather definitely changed the epidemiology and the time, it's the seasonality of the infection itself. But regardless, because of the nature, the reactive nature of the disease, you can definitely see it year-round. Something else that we find is where the patient presents. So that graph seems a bit overwhelming in the beginning, but it's really easy to understand, so I'll kind of walk you through it. So here in this column, this is all Lyme disease. Here is the recurrent. I was a bit more interested in the one that acute. They are the one that it's a bit more challenging to know what's happening with them right now. So out of the 67 patients with acute Lyme arthritis, the vast majority, all the blues, presented to the primary care physician. They're definitely the first line of defense when dealing with that. But then there was a substantial number that went presented into the ED. 39% of them end up being referred to a specialist, and specialists for Lyme arthritis are sports med, ortho, rheumatology, and ID. And they're kind of a nice distribution between those groups. So there's a nice chunk of patients that are being referred, but also look how many primary physicians will see Lyme arthritis, diagnose it right, recognize it, treat it, send the patient home, and this is it. And I was very happy to see that there is a substantial number that, not there yet, that can work with that. But when they do end up at the ED, that kind of prompts them to end up in the hospital. So you can definitely discuss about the bias. Maybe those who have bigger swelling or look a bit sicker are the ones who present to the ED, and this is why they end up in the hospital. I'm not sure this is the case. I think it's about who is dealing with them. And many of the patients with a joint swelling that can end up go to the ED, the first consultant that get the call about them are the ortho surgeons. And if a child with a swollen joint get a call to the ortho surgeon, this is a 99.9% sure they're going to end up in the surgery at one point. So this is, again, something that we're trying to work with to see why so many kids are being admitted and if you can do anything about that. The joint distribution, and this is the numbers that we got from our cohort, which really is similar and resemble to what you will see in all the other big cohorts. So definitely the knee is the most common, but 5% in the ankle, 5% in the hip, 8% in the elbow. And again, you can keep on reading that. But when you look at it like that, I think it's only half the story. The better part of the story is this fly diagram. So I was trying hard to make it into a tick, but my graphic design abilities stopped here. But it still tells a story. So this is a Venn diagram. Everything inside the red is involving the knee somehow. So 88 patients had acute monoarthritis of their knee. So by far the most common presentation of Lyme arthritis, it's acute monoarthritis of the knee. But on the other hand, there are a lot of patients that will have it in the knee, in the shoulder, in the knee, in the fingers, in the knee, in the wrist. Out of the 109 patients, only 2 patients, again, only 2 patients did not have involvement of their knees. And one of them had isolated hip arthritis, and one of them had isolated elbow arthritis. So it's definitely not a disease only of the knee, but it's definitely a disease where the knee is the most important joint that we need to think about. You'll see it every now and then in other joints. But it can, the knee, the knee, the knee, and the knee again. I'm going to say knee a lot. The night will say knee. So kind of finish this part of what we spoke about. So the clinical setting, as we said, the primary is where many of them are presented. A big chunk is being referred. And then again, kind of a 30% to a quarter being presented to an ED, and then some of them end up in the hospital. Seasonality, it's a year-long disease. Here I get to say the knee again. Admission rate. Now, when you look at the admission, you see a direct correlation between the synovial white blood cells fluid count and admission, which make a lot of sense because the reason the kids are being admitted is because they have more than 50,000 white blood cells and they're defined as septic arthritis. But again, if you look at the number, you see that a tap and a high white blood cell count in your synovial fluid is a high risk for admission. Overall, from the data I showed, you can see that Lyme arthritis is common both as in the community, so you definitely see it a lot, but also a common in presentation. The curveball are very occasional. Most patients with Lyme arthritis are very easy to recognize, and they kind of look all the same. And we keep on talking about admission, we keep on talking about septic arthritis, we keep on talking about synovial blood fluid. So part of what I'm doing here is also rethink this whole approach to AIMA, what I call the acute isolated monoarthritis. So, a few words about evidence versus dogma. So when you open any literature, when you go to UpToDate, when you go to a review article and you click septic arthritis, that's what you're going to get. Bacterial invasion, staph aureus, patient are usually sick, gold standard of diagnosis, it's isolation, and then you get those two. Diagnosis is suggested and often confirmed by synovial pleocytosis more than 50,000, and often considered as an emergency due to concern of associated high morbidity and mortality. So, this 50,000 will always confuse me, and I was like, why, where, who, I mean, what is the evidence for that? And the thing that all the papers that you read about it refer back, and there's always referral to like a review from 10 years before, some article 5-10 years before. But if you do go down that rabbit hole, and you use the internet, you end up with the Holy Grail, with the origin of it all. So in 1960, there was an article that was published by Ward and Cohen, and the diagnosis and therapy of acute suppurative arthritis. And they reviewed 24 cases, not 2,400, not 24,000. They reviewed 24 cases. 8 of them were children. 18 had proven septic arthritis. 6 had probable septic arthritis. The synovial white blood cells range they found was between 25,000 to 250, and that's the information they have. There's nothing else. And they end up saying that if you see more than 50,000, think suppurative, invasive. And ever since then, that's what we're referring to. So every time we say 50,000, it's based on a 24-patient series that, again, I don't understand how they end up with that statistic. So, dogma, it's that one think is true. And the thing is that it's so embedded in everything we do with joint that even when other people publish really nicely written and designed work like the cohort criteria, where they were trying to figure out which of the hip arthritis need to get tapped or not, they were using 50,000 as their gold standard for diagnosis. And more than half of their patients with septic arthritis were defined as septic arthritis based on nothing else except of the 50,000. Which means it's so embedded that all the information we build on septic arthritis following that was on this 50,000. And as I showed, there are some other reactive diseases that can do the same. So be careful with that. And then some other point that come up in a review article is that septic arthritis is a potentially devastating disease that may cause permanent disability or even death. I'll go quick over that, but same story here. If you really go down the reference line, you see that this is really not the case. And when papers are looking at isolated joint infection in kids and kind of divide them by age, so in 1986, there was a review done in Glasgow of 61 children, and that's a good number. And they divided them into groups, and 29 of them were above 1 year and had septic arthritis outside of the knee. Only 2 of those kids had a bad outcome, and those 2 kids were delayed diagnosis for 2 to 3 weeks. Then they have a lot of other kids that were delayed diagnosis for 1, 2, 3, 4 days, and all of them did great. I'm saying that because part of what I think need to be done, and part of the algorithm I'm going to suggest about how to manage kids with arthritis, has to do with the fact that it's okay to delay the diagnosis of septic arthritis for 24 to 48 hours. The risk of over-treating is probably higher than the risk of waiting a day or 2. And when we looked here locally about this whole question of septic arthritis versus a bit more invasive disease, so when you think about septic arthritis, it can be divided into a musculoskeletal infection that is more invasive and involves the joint, the muscles, and the bone. As you see in our series, we had 7 of those as compared to 11 kids who had only isolated monoarthritis. But you just look at this table quickly to see that this is a different story. Those kids with the musculoskeletal infection, many of them had a positive blood culture. They were sick. I mean, you could see on them that there is more going on than just a swollen knee. On the other hand, this group looked exactly like any one of the Lyme arthritis kids. And I think it's close to impossible, and probably is impossible, to just clinical exam-wise just look at a child and tell if he had the Kingella arthritis or Lyme arthritis. But I am saying that those two diseases can wait a day or two until being diagnosed and managed. So what to do? So when we do get a child with acute arthritis, first thing to do is to see if there is any underlying illness or any specific risk factors. So if that child just had a bone marrow transplant 2 weeks ago, this is not what we're talking about. Deal with that. So this is not like an acute isolated monoarthritis. So anyone, or if, again, kid every now and then show with a nail impaled into their knee. This is probably not Lyme arthritis that give them the pain. So definitely do not treat those patients if they have Lyme arthritis. Next step is to look at the toxic appearance and kind of the general appearance, and maybe do an MRI to figure out if that's only the joint, or there also some muscle and bone involvement. If you think it's a bit more extend to more than just the joint, it's admission to the hospital, it's NPO, it's surgical procedure. In this choice of antibiotics, try hard as you can to get a sample before giving antibiotics, but if it's not working, give the antibiotics, don't just wait. For those kids who kind of say no to both of those questions, Lyme arthritis must be considered. So basic lab like CBC, CRP, ESR, blood culture, Lyme studies, and arthrocentesis. And there are two asterisks there because arthrocentesis is definitely not a uniformly rule. A lot of patients could be diagnosed with Lyme arthritis without a tap. But if you have a question tap, the knee is an easier body compartment to get some fluid from. But after you tap, I strongly feel that with a good follow-up, those patients can be discharged home. I fully agree that this is not a common understanding right now, and some people are a bit more concerned. But even if you admit them, you should admit them for just observation. No antibiotic need to be used. Just wait 12, 24 hours, see what the results take you, because if in the next 12, 24 hours you can get a positive blood cultures, a positive culture for the synovial fluid, positive gram stain, septic arthritis, and we know what to do with that. But if not, wait another day or two, because it's very likely you're going to get the result about the Lyme arthritis, and then this is an outpatient management with doxycycline and follow-up. If both of those are negative, well, there's a lot more to look at, but not for today. So, as I said, that was just part of what I'm doing, and that was very interesting, but that definitely, when I was looking at all the numbers of Lyme disease, that specific screen test caught my attention. And then I said, in 2015, Fairview changed of screen they're doing, and we started getting it like that. So positive and a number. And this yellow line with above 12.4 is something that I kept on seeing again and again and again and again. I had really, again, at that point I didn't even know what the difference between the tests. As you guys know, the name of the test in EPIC tells you nothing of exactly what it is done. And serologies are notorious that when we say the word this and that serology, it really has very little meaning to the exact test that is being done. There are different modalities to do that, and it's very confusing for us as providers to really find this information. So it took me a while to kind of think, okay, so what this is, and a couple of phone calls, and I was able to get the product insert from the lab about the specific tests they're using. And apparently they're using a test that's called CLIA, or chemiluminescence. Again, this specific antigen called VLSE. So this test, you take a magnetic particle and you coat it with Borrelia VLSE antigen, recombinant antigen. You pour the patient's serum on it. If the patient has specific anti-VLSE antibodies, they're going to bind to those beads. More of those antibodies the patient have, more of them going to bind to the beads. There is a point of saturation, and this is why 12.4. So at one point, there are just so many beads you can put there. And if all the beads are saturated, you'll call it above 12.4. Then you add another mouse monoclonal antibodies that also have some fluorescence, some chemoluminescence into them. You put it under the machine, and you get a read. Quite simple when you think about it. So a few words about this VLSE, about this specific surface protein. So it's a variable surface protein that is essential for persistence. So there's mouse model showing that if you knock out that specific surface protein from the Borrelia, nothing is going to happen. Chronic disease or any significant disease is not going to happen. So we know it is essential. What we also know that it has an expression site, but it also has 15 silent cassettes. And what is fascinating is that as long as the Borrelia lives in the tick, as long as either in the midgut or in the salivary gland, nothing is really happening. It's only the kind of the constant region is being expressed. You can find some of it on the cell surface, but really nothing really happened. The second the Borrelia enters the host, the mammalian host, something happened there and a gene conversion starts shooting variable antigen to the surface of the Borrelia. Now we know that despite this antigenic variation, still there is a very generous antibody response. And we know that from mouse models. Again, they took mice, they gave them they gave them a Borrelia and they start counting the antibodies. And they saw that although it's very variable, the antigen variable on the bacteria itself, the mouse do produce enough antibodies, or in fact, antibodies. So now it was very confusing to me. So if the body does react to that, why is it so important for the infection? So why is it not helping the body get rid of the Borrelia? And there are two theories behind that. One theory is that the VLSE somehow physically shield other antigens from antibodies. The other one that I find much more interesting, and I think it's kind of more correct, is that it's mediating an immune exhaustion, which was a new word for me when I started treating, which means the immune system is working so hard against this ever-changing antigen that is allowed the Borrelia with some non-variable antigen on it to escape and get some persistent and produce a chronic inflammation. Borrelia, by the way, it's not the only organism that does that. Trypanosoma, malaria, and relapsing fever all have kind of the same concept. So the second part of the study was to try to evaluate if this specific anti-VLSE CLIA test is good for the diagnosis, good for Lyme arthritis. I mean, it's really what I saw, all of those high numbers mean something. So we went back to for the Fairview database, and we were able to collect all of the Lyme screens that were done and all kids 1 to 18 years old in Fairview for a period of 2 years. Then all the negatives were kind of tossed aside, and we reviewed all of the positive in the same way that I showed in the previous study to see who we can confirm Lyme arthritis at. And by the way, the study protocol, both of those were reviewed and approved by IRB. So overall, we found 2,300 Lyme screens that were done during the study period, but only 175 of them were positive, about 0.9. So first, I was happy to see that this is not something that everyone turns positive. So this is not like, notoriously the traditional Lyme screen, the one that uses a wholesale lysate with an EIA assay, has a very high rate of false positive. When you do this test and when you know how common Lyme disease is in Minnesota, and you assume that at least most of those tests were done on patients that had a good reason to do that, to end up with 175 positive out of 2,300, it's pretty good by itself. Then out of the 175, Lyme arthritis was confirmed in 46 patients, and every single one of them had a value of above 9. So not only had it positive, but their values were very, very high. And then there was another 18 kids that were diagnosed with Lyme, not arthritis, and only 3 of them had values below 9. So I thought there was a story here. There was a story to tell. There was a story that was very interesting. So this is kind of a graphic presentation of the results. So all of the Lyme screen, 2,300, 93% of them negative, 175, 70% is positive. But when you put the positive on this kind of chart, and every little line is a patient, this is the value of the VLSE, and I color-coded it. So darker black are the highest, lighter are the lowest. And again, let me remind you, those are all positive results. All of those results come with a yellow line. It is positive and a number. But then, when you look at the diagnosis, again, you do not need to be a statistician to see the statistical story here. They're all kind of focused here on the higher number. There are not a single Lyme arthritis under 9. And in fact, under 12, there are hardly any patient. There is one line here, and this that I'm a bit confused, and I have a feeling that he did have Lyme, it just was not diagnosed, but I cannot go back to a chart and add what I want to add there. So this is a patient that does not carry the diagnosis of Lyme. But out of that singular patient, every single one above 12 had Lyme disease. This is a high specificity and a high sensitivity test when you use 9 as the cutoff. Another piece of the story is this beautiful correlation between the value of the anti-VLSE and the IgG Western blot. And it's a one-to-one. I mean, those who had a high value anti-VLSE are the one who had high band number on their IgG, which means the 4 days we're waiting for those, it's kind of a waste of time, which means if you suspect Lyme arthritis in someone and you get this specific screen test, which by the way, they're commercially available for us. So when you go to Epic and you put Lyme screen, that's what you get. You do not need to know more about that. I cannot promise, I don't know what Children is doing, by the way, and I do not know what other places are doing, but here for Fairview, this is what your Lyme screen. And those results come back with 12 hours or the following day. You do not need to wait too long for them. And I was also really struck by how IgM has kind of tells his own story. That I don't completely understand what it is, but definitely there is a own story that tells. When I presented this information at IDSA, there was a reporter from again, I always forget what the name of the magazine that was kind of looking for stories. So he interviewed me, and he came up with an awesome tagline that I'm going to use, which is, if it's above 9, treat for Lyme. So I owe my title of the talk to Jeff, and I owe if it's 9, it's Lyme, to that guy. But remember that. For that specific screen, it's very useful. So this quantitative immune assay detecting clonal antibodies against Borrelia surface VLSE protein seems to correlate very well with Lyme disease. For children presenting with acute knee arthritis in a Lyme endemic region, highly positive results are indicative of Lyme arthritis. And utilizing this approach will facilitate timely diagnosis and prevent unnecessary hospitalization. Overall, to this point, what I've learned out of everything I did with Lyme are a couple of things. First, that Lyme must be suspected clinically in any patient with arthritis. Really. Think about it. I don't know if this is the case, but it's common enough that always have it on your differential diagnosis. Patients present across the clinical setting. We should all be familiar with that. I mean, they can show up in any clinic, and they can show up with your friends, your relatives, your neighbors. It's definitely a disease that every single one of us is encountering, so it's a good thing to know something about it. Labs are not very helpful, but attention should be given to ambulation, fever, and peripheral white blood cell count. Septic arthritis has a spectrum of pathology and not always should be considered as a medical emergency. And differentiating between invasive musculoskeletal and acute isolated monoarthritis is important and very helpful in the management. And yeah, this anti-VLSE screen is useful. So when you go back to the model of immune dysregulation, so I think we were able to at least move a bit the indicator about what Lyme arthritis look like. We found that these anti-VLSE antibodies, and I was extremely surprised not to find a similar correlation in humans. There are studies that correlate the anti-VLSE to the IgG's Western blot levels, and this is how they got the product approved, by showing, hey, we show the same thing as a Western blot, which we know it's true because that's what the graph showed also, but also either by the company itself and also when you look at the literature, this correlation between clinical disease and high value, it for some reason was not done. So I was happy to be able to add this little piece to the puzzle. And we know what's causing it. We know the microorganism. So we're far away from figuring out Lyme disease and the immune dysregulation go with it. But I think studies like that are very helpful because it really show that in a such complicated system like the immune system, every little piece of a puzzle helps and moves some. And if nothing else, it gives you some work to do later. What I think about doing with this project is now when we're able to kind of well define the groups to try to see what story do they tell. What story do the acute monoarthritis versus recurrent polyarthritis tells in their types of genes, their cytokines, where they live, who's their family, and so on. So that's what I would have to say about Lyme today. I would like to thank a couple of Megan and Mackenzie, who were students that helped me in the beginning of the project. Shannon, one of the fellow who helped me with septic arthritis and musculoskeletal infection. Liz Butler, another student that helped. AJ, that recently got involved in working with that data. And then Jeff and Brenda for their guidance. And I'm done. Thank you.
Thanks, Bazak. I'm curious about the new test in terms of its sensitivity. I presume it's good because the lab has replaced the old ELISA with the new CLIA test, but you didn't analyze any of the patients with negative test results. What fraction of those patients had Lyme arthritis?
So yeah, it's a question I ask myself and I keep on being asked. Those are 2,200 patients that I have not found the time yet to do that. I think there needs to be discussion how important it is because, as you said, I assume they're all negative, just because we kind of know that about the AIA test, and also it was part of when they got approved for the product, they were able to prove their sensitivities to show that they do not have false negative. But we definitely have the patient population that if I find another student here to help, we can definitely go through and see are there any Lyme diseases there. Yeah.
So thanks, Bazak. So at the very start of this, you kind of had a disclaimer, these are normal kids. We're talking about the kid that had the BMT another time. But we care for a large amount of immune-compromised kids in an area endemic with Lyme disease. I'm just wondering if there are any caveats about presentations in kids with immune suppression.
So I personally have not seen Lyme arthritis in someone who is... every now and then we'll get the solid organ transplant, but there are the healthy ones that spend some time at the cabin. I do not consider that as, opportunistic infection or have a different presentation in the severely immune compromised, but I do not know that.
Great talk, Bazak. That was really, really good. To follow up on Joe's point, I haven't seen it either, and that's kind of interesting, isn't it? That maybe kids that have chronic diseases or on iatrogenic immunosuppression just aren't outside getting tick bites. Appreciate the Monty Python reference. This is a disease where we need a vaccine, isn't it? And I wondered if you had any comment on that.
No, you're not going to find me standing here saying something bad about vaccines. But unlike other diseases, for instance, CMV, that I don't think there is any way to ever deal with without a vaccine, Lyme arthritis, it's quite easy to prevent. If you put DEET on yourself, if you take out the tick from yourself, if you pay attention, you're not going to get Lyme. You're really not going to get Lyme. So, again, great if we can find that, but I personally think that more energy and effort can be focused elsewhere than a vaccine specifically for Lyme. And it's also a very simple disease to deal with. Yeah.
Back here.
Oh.
Hey. Yeah, so towards the end of your talk, you had hypothesized immune dysregulation as a central component of this pathophysiology. And at the very start, you had mentioned molecular mimicry in particular as one potential mechanism. My question for you is, do you see in appropriately treated Lyme arthritis kids that they end up having a heightened sensitivity to an inflammatory arthritis down the road, independent of like a recurrent Lyme arthritis?
So,
I'm wondering if this predisposes you to actually like
Yes,
other
yeah.
inflammatory autoimmune diseases.
I mean, if I understand your question right, so I do not have the specific patient to show that, but share the thought that Borrelia can trigger ongoing lifelong arthritis, also outside of the kind of acute. Yes, so I'm sure there are GIA patients out there that were triggered. Or at least we call them GIA because we don't have any other name for that were triggered. And again, I mean, Bryce probably can say more about that, but I definitely think it's a thing.
I just wanted to follow up on Mark's point. There was a Lyme vaccine on the market 2 decades ago, Lyme-Rix, based on an outer surface protein A, OSP-A of Lyme. It didn't do well in the market, so it's no longer in the marketplace, but a fair number of patients who got that vaccine did develop arthritis, which gets to your point of how the immune response to the bug is through immune dysregulation, it may be driving the arthritis. So if you're thinking about vaccine design for Lyme, you have to be careful that you're not inducing the immune response that's causing the pathology.
And about that, Joe is not here, but when you ask about the immunocompromise, it almost seems like you need to have a working immune system to be able to dysregulate it enough to get arthritis. You need, again, the arthritis is a self-inflicted wound. It's a working immune system, but at one point it got dysregulated. I think it's hard to do on the fourth floor when there's no immune system.
Thank you very much.
You have been disconnected from the meeting.